Yeah, we coming up in a few minutes. Okay, the video now. And then Ashley would start after.
Welcome, ladies and gentlemen. Namaste, Assalamu alaikum, and good evening, good night, and good morning to all of you. We are pleased to have people at this meeting from all parts of the world in different time zones. I am Ashley Sinanan, an independent researcher specializing in historical studies. I hold a bachelor's degree in history with a minor in literature from the University of the West Indies. Ladies and gentlemen, this is the 296th edition of our ICC Thought Leaders Forum. We wish to sincerely thank all of you who have contributed in whatever way to the success of this ongoing Pan-Indo-Caribbean and Pan-Indian Diaspora Global Grimitia project. For 295 unbroken continuous weeks, we have been here every single Sunday. In the past 5 years and 9 months, we have featured 1,189 presenters from all parts of the world speaking on 295 topics. Ladies and gentlemen, this is a weekly forum being hosted by the Indian-Caribbean Cultural Center, a legally registered research and publishing company operating since 2010. In order to continue this weekly program and to make it better and bigger, we are asking for suggestions and volunteers. If you give a donation, your name will be placed on our poster and all promotional materials. Please contact Dr. Mahabir for details. Today, our thoughts and prayers go out to those living in the USA and Canada who are undergoing the extremely cold weather. A massive snowstorm is now affecting 200 million people in the USA, the biggest in several years. Everyone is affected, is urged to take necessary precautions and inquired about loved ones and neighbors. We also wish to join our brothers and sisters in India as they celebrate their 76th Republic Day tomorrow. With that being said, ladies and gentlemen, let me introduce our moderator today, who is Shalima Mohammed, the co-director of this ICC Zoom platform, who is a business teacher and researcher from Trinidad and Tobago. She obtained her master's degree in business psychology from Franklin University in the USA.
Thank you very much, Ashley. Assalamu alaikum, everyone. Namaste and a warm welcome to all of you from a very hot Trinidad and Tobago. Thank you for choosing to be here with us. This program is recorded on Zoom and live streamed on the YouTube channel of the Indo-Caribbean Cultural Center. So welcome to all of you on YouTube. And thank you for joining us despite the fact that it may be cold where you are. To our speakers, to avoid intrusions from trolls, our IT manager has muted everyone. So please do not admit anyone, do not unmute anyone, and do not allow anyone to share your screen. Thank you very much for your cooperation. Today we are talking about non-communicable diseases arising from alcoholism. And why is this important to us? Persons of indentured Indian heritage have a particular interest in understanding non-communicable diseases arising from alcohol abuse due to the historical, biological, and sociocultural factors shaping health outcomes in these communities. During the indenture period, alcohol was often introduced and used by colonial authorities as a tool of control and coping on plantations. Its use was normalized in the harsh labor environments to deal with trauma, displacement, and social breakdown. Those patterns did not disappear when indentureship ended in 1917. In many descendant communities, problematic drinking became intergenerational, tied to stress, masculinity norms, and economic hardship. This legacy intersects with existing genetic and metabolic vulnerabilities. People of Indian ancestry often have higher metabolic risk at lower body mass indices, meaning alcohol-related damage can show up earlier and more severely than expected, and increases susceptibility to cardiovascular disease, diabetes, and liver disorders. Unfortunately, cultural stigma and limited discourse surrounding alcohol-related harm have hindered early intervention. The government of Trinidad and Tobago, led by the Honorable Kamla Prasad Visesa, has significantly increased excise duties and taxes on alcohol from this year to curb consumption and reduce abuse. But that has met with, well, as is expected, some difficulty. For many descendants of indentured laborers, learning about alcohol-related NCDs is therefore important. Firstly, to understand how colonial systems shaped current health outcomes. Secondly, to reclaim bodily autonomy and community well-being. And thirdly, to design culturally relevant prevention strategies. And this is what we hope will be the outcome of today. So, ladies and gentlemen, let me welcome our first speaker, and this is Dr. Rohan Maharaj from right here in Trinidad. He's the first professor of family medicine at the University of the West Indies, the alcohol policy advisor for the Healthy Caribbean Coalition, and author of the book titled Rum Songs and Other Works on Alcohol-Related Issues in the English-Speaking Caribbean. Welcome, Dr. Maharaj.
Good afternoon, Shalima. I think that was a wonderful introduction, and I suspect I don't have to say very much again. But it was a wonderful encapsulation of all the issues that this has been discussed in this forum in the past, and also some of those things that I hope to cover on today.
Thank you.
So, just good day, everyone. Thank you for that wonderful introduction, Shalima. And as mentioned, I'm a retired professor of family medicine at UWI St. Augustine and the alcohol policy advisor to the Healthy Caribbean Coalition. I'd like to thank the Indo-Caribbean Cultural Center for this opportunity to present on alcohol and non-communicable diseases and an amazing 296 edition of your webinars. Congratulations, heartily. Although I'll be talking about non-communicable diseases today, it is always important to remind ourselves of the wider impact of alcohol on families and society. The narrative on the slide reminds us of the mental health challenges provided by alcohol, and not only to the consumer, but also to their families. And this tells you a little bit about two recent patients that I've saw at my practice who had symptoms of post-traumatic stress disorder. And they both, amazingly, and this happened like within the space of a couple of weeks, they both said almost the same thing. When he drinks, it's like a different person, a beast. I become anxious, waiting the blows that may come at any time. And these patients presented with anxiety-type disorders. And they were not alcohol users, but the family were. Unlike tobacco, alcohol does not have that one big condition that is lung cancer, for example. Instead, alcohol contributes to over 200 medical conditions. For this presentation, I will focus on those conditions highlighted in the black font: cancer, hypertension and stroke, depression, liver cirrhosis, and to some degree, pancreatitis. How does alcohol cause harm? Many factors play a role. Societal factors such as alcohol policy, the drinking culture, the drinking environment, and the healthcare system. Demographic factors such as age, gender, and income, all these interact to affect the volume, patterns, and quality of alcohol consumption. Including here is the role of ethnicity, which is especially important to those of South Asian descent, and I'm glad that Shalima brought that up in her introduction, and we will touch on that briefly at the end of this presentation. All of these factors together affect the development of chronic diseases and morbidity and mortality. Alcohol creates harm through its intoxicating effect. It creates impaired judgment, loss of motor coordination, and mood swings. It has direct toxic effects, including cancer risk, immunosuppressant effects, and teratogenic effects. We all know of its issues around dependency and its interaction with other substances where alcohol causes other substances to have greater side effects. These intoxicating effects I mentioned before can be mild, moderate, severe, and extreme, almost to the point of causing death. For those of us who may have a chronic disease, who have hypertension, or may have to be on certain medications like antipsychotics, anxiolytics, and so on, it's important to know that the alcohol-drug interaction is a critical part of how it causes ill health. And almost every single hypertensive drug, as listed here, all of the drugs that have a sedative effect, such as the antidepressants, antihistamines, anxiolytics, hypnotics, anti-diabetic drugs, some of the drugs that work to thin the blood, such as coumarin, and medicines such as metronidazole, ketoconazole, and common metformin. All of these drugs interact with alcohol. And if you're on any of these medications, and these are commonly prescribed medicines all over the world, you should be very careful using alcohol. Focusing a little bit now on the next few slides on cancer. Alcohol contributes to the causation of cancer through 5 mechanisms, and 4 of them are listed here. One is through the breakdown of ethanol through alcohol dehydrogenase, which creates acetaldehyde. And acetaldehyde is a class 1 carcinogen, affecting the DNA damage as a result. Similarly, alcohol creates oxidative stress, which increases the risk of cancer by damaging DNA, proteins, and cells, causing inflammation. Alcohol alters the levels of multiple hormones, including estrogens, which can increase breast cancer risk. And combination of alcohol with tobacco, what it does is it increases the carcinogen uptake because the alcohol alters the cells in the mouth and the throat. The 5th way that alcohol contributes to cancer formation is that it damages the cell lining in the stomach and the intestines. This impairs the body's ability to break down and absorb cancer-protecting agents. These agents would normally protect you, but because of the damage of alcohol on the intestines, it's not able to absorb these chemical compounds. And these are things that are present in our diet, such as folic acid, vitamins A, B, C, D, and E, and carotenoids. These are all things that work to help to keep our body healthy, and alcohol can reduce its absorption. So I'm going to spend now the next few slides talking about some specific issues that develop around alcohol consumption. So I hope you can see my pointer. Spend a little time to explain this graph, because when I explain it, then you'll be able to better understand. It can look a little daunting. So this describes 4 different cancers: mouth and oropharyngeal, esophageal, liver, and breast cancer. It also talks about diabetes, but I'll talk about that specially. So it talks about the presence of these 4 cancers, and when you use alcohol, what happens to the risk attached to this use. And in this slide, we're talking about 3 different levels of consumption. And the levels are listed here. For females, this is 1 to 2 drinks a day. For males, this is 1 to 4 drinks a day in the blue, and it goes up in that direction. And what this is telling us is that for mouth and oropharyngeal cancer, as you increase the rates of alcohol, you increase the risk for developing this cancer. And you see very similar pattern for esophageal, liver, and breast cancer. Now, this first four rows and columns here are the basis for the WHO 2023 pronouncement that there is no safe level of alcohol consumption, right? And that's because, as you see here, even at the lowest risk, your risk relative to people who are not drinking is higher. So if you're looking at mouth and oropharyngeal cancer, you're 1.4 times more likely to develop that compared to a non-drinker, even if you have the lowest level of alcohol, maybe 1 or 2 drinks a day. And that is for all of these conditions. You see here 1.45, 1.8, 1.45, 1.15. But look at what's happening with diabetes. You're actually below the level of 1. What this is telling us is if you consume small amounts of alcohol, compared to a non-drinker, you're protected from diabetes. And I know that's going to sound a little controversial, but I'll explain to you some of the consequences and ramifications of this bit of information, right? So the evidence seems to be very clear. This evidence has been supported time and time again by the International Authority on Research in Cancer, which is an organization affiliated with the World Health Organization. And it's really based on this that the WHO made that pronouncement in 2023. Now, low-dose alcohol seems to improve insulin sensitivity and raises some hormones called adiponectin, which reduces insulin resistance. Low-dose alcohol seems to also improve your HDL, which is what we know as the good cholesterol. So it's doing some good in terms of diabetes. But remember, if you drink at the lowest level, you may protect yourself from diabetes, but you increase your risk for the cancers. And this is where we're starting to sort of develop guidelines for individual advice on alcohol, and I'll share some of that with you at the end. But there's another side to the diabetes equation, and I try to demonstrate that on the next slide. And that is that as you increase your alcohol intake, you increase the risk of developing acute and chronic pancreatitis, right? And you see here that if you go very easily above 3 drinks a day, there's a very drastic rise in your risk of developing pancreatitis. And once you develop pancreatitis, there's a 30 to 40% increase of the risk of developing post-pancreatitis diabetes. And so you might think, well, a small amount will protect me, and that seems to be the case. But if you carry your drinking levels up, you increase your risk of pancreatitis, which can then put you firmly into the diabetic state. Right. I'd shown this slide, I think, the last time I presented, but I don't know if I was able to go through it in detail. So as I have a little more time today, I'll show it. I shared some of the information again. One of the very special things that the research is showing us is this risk of breast cancer. And very similar to what we showed before, whereas those slides, that information a couple of slides ago was for the average person, this now breaks down the individual risk. So if we start with the lowest, the orange line, if you are a younger person of normal weight and no family history, compared to someone who is not drinking, your risk is very little, at 1, same risk as someone who is not drinking. And that risk goes up marginally to about 1.2 over as your alcohol intake goes up. But if you're younger, of normal weight, and a first-degree family history, this green line, you start off with a higher risk because of the family history. You're twice as likely to be starting off at a base, even with zero alcohol per day, you start off with a risk of 2, and that goes up to 2.5 depending on the amount of alcohol that you intake. And if we jump up then here to this other person here, which is an older, overweight female with a first-degree family history, you start off with a risk of almost 5.25, and that risk goes up to 6.5 times more likely to develop breast cancer with an increasing level of alcohol. So this is, again, the sort of straight line curve is telling us that there's no protection, there's no safe level. And so you're depending on your individual characteristics, it then helps you to understand what your risk might be. Similarly, recent data, not too long ago, 2 years or so, was published showing the risk of colorectal cancer with alcohol intake, and results show that higher intakes of alcohol and white bread are associated with increased colorectal cancer risk. And we have some protective components there: dietary fiber, calcium, magnesium, phosphorus, and manganese give you some sort of protection. So again, helping us to get information about how our diets can protect us from malignancies. And so whenever we present this kind of work, one of the questions is, but I thought that a glass of wine is good for the heart. And the evidence seemed to support this. What this graph shows is that compared with someone who has no alcohol consumption, small amounts of alcohol, 1 or 2 drinks a day, reduces your relative risk of coronary heart disease compared to someone who doesn't drink at all. And however, you lose that risk as you go up to 4 or 5 drinks a day. That risk now starts to shoot up in a straight line. But this is only for coronary heart disease. Let's look at some of the other cardiovascular diseases. So the ones in the red circles here tells us about that protective event. So this is coronary heart disease, where you get some protection. Ischemic strokes, where you get some protection. But let's look at hypertension. Remember, when you drink, you might be protected here, but you're getting other problems. So hypertensive heart disease goes up. Hemorrhagic stroke goes up, and this graph is set basically and similar to the parameters I described before, right? And this is for males, right? So your risk of hypertensive heart disease goes up by a factor of 4. The risk of hemorrhagic stroke, which is a bleed, usually in the brain. These are the much more destructive types of strokes where people become usually permanently paralyzed. Okay, and other cardiovascular disease, so peripheral artery disease, for example, these are other things that happen as a result of alcohol use. So it's really only for coronary heart disease. So you say, well, I'm getting protection, but you're getting protection about one particular condition, but not from the others. And that's where you have to be very, very careful. For women, the stories are a little bit better for coronary heart disease, ischemic strokes, and hemorrhagic strokes. But for hypertension, there's a 2 times increase of hypertensive heart disease for alcohol use, higher, moderate and high alcohol use in women, and then a sudden rise of hemorrhagic stroke. You go from almost being protected up to a very high level of risk with higher levels of alcohol use. So I'm just going to talk a little bit now about some of the work that we've done in the region and how that helps us to understand from our perspective of Caribbean people. And this was a study we published last year talking about alcohol use, heavy episodic drinking, and associated cardiovascular risk in Guyana. This was based on the 2016 STEP survey, which is a PAHO-related survey. And what we found in that is that younger males were significantly more likely to consume alcohol. And we found that the Indo-Guyanese were the ones who, unfortunately, were showing up this higher level of alcohol use. People of African and Amerindian descent had lower odds of heavy episodic drinking. And when we analyzed the data, we found that heavy episodic drinking, that's usually 4, 5, 6 drinks in a sitting, usually in a sitting less than 2 hours, they found that these people had higher blood pressures, higher levels of obesity, and higher levels of triglycerides, which is a fat in the blood that's usually measured with cholesterol. And these are all risk factors for cardiovascular disease. Now, this was a cross-sectional study, meaning it was taken at one point in time. And so we weren't able to follow these people up to see what was the subsequent outcomes. Those studies are much more difficult to conduct. But a similar study was conducted in Tobago, which was one of the most powerful studies, and we should really take the information from this study to heart. This was a 30-year study looking at mortality in Tobago, looking at the impact of glucose intolerance, which is almost like a pre-diabetic state, and alcohol intake. And what they found is for younger men under the age of 60, high sessional alcohol intake, which is again that heavy episodic drinking where they sit and they drink maybe 5 or 6 drinks in a sitting, usually over 2 hours or less, explains about a quarter of all-cause mortality. All-cause mortality is the kind of mortality just dying from anything, not specifically linked to heart disease, but overall. So it'd be accidents, deaths from liver problems, deaths from stomach issues, bleeding, anything. And it explained 40%, about four-tenths, two-fifths of cardiovascular mortality in the under 60. So we know that over 60 people are going to die from heart disease and so on. But this is telling us that if you drink and people follow you over time, your risk of earlier death increases significantly. So this is one of the more powerful studies we have in the region. We know that the Tobago population is a little bit skewed towards the Afro population, but nevertheless, it's done work that's done regionally that's telling us that even our Afro population, our Afro colleagues and so on, are at higher risk when they use alcohol in high levels. And that's the same sort of basic pattern that we're seeing coming out of that Guyanese study. And the increased risk of cardiovascular mortality explains why so many of our younger men may have sudden death, for example. Right? Talking a little bit about liver disease, we know that alcohol contributes significantly to liver disease. And this is looking at the risk of liver cirrhosis by just taking an increase of 3 to 5 alcohol drinks per day. The risk goes up to, for women, up to 10 times the risk of liver cirrhosis. And usually there are many stages. This fatty liver, for example, is one of the stages that occurs. And many of our population people we send for an ultrasound now are coming back with grade 1 fatty liver. And that increases your risk of liver failure, especially if heavy alcohol take is contributing to the issue, right? One of the other things, again, looking at the mental health issue, is that is the link between alcohol and depression. And what we find that this is a bi-directional nature. So people who drink become depressed, and people who are depressed tend to drink. So it's sometimes not easy to decide which one comes first, but what we know is it is strongly related in both directions. So 16% of among those who are depressed, 16% have a current and 30% have a lifetime history of alcohol problems. And this is the basis for what we call this dual disorder sort of conditions that we see in psychiatry, very often mental health disorder along with a substance use issue. And we do know that in many international studies that about a quarter of all suicides are associated with recent alcohol use. Among people who have alcohol use disorders, there's an increase in depressive symptoms. And these symptoms predict greater alcohol impairment and poor treatment outcomes. So, we are not only seeing the chronic disease from the cardiovascular and from the liver and so on, and from the pancreatitis, but we also see some of the mental health. We had that second slide I presented looking at the impact on the family of users, and now we're seeing it in terms of depressive illnesses. Right. I briefly presented this slide the last time I was here. Basically, it was an attempt to sort of pull all these different kinds of data that we're getting across the region. Some of it narrative reviews and some of it qualitative type research, but some of it's pretty hard science too. And so Shalima mentioned the genetic susceptibility. And we know that people of South Asian descent have a genetic susceptibility in that our alcohol and aldehyde dehydrogenases sometimes don't work as well as other races, right? We know that there's increased baseline metabolic and hepatic vulnerability, non-alcoholic fatty liver disease, type 2 diabetes, and adiposity, being overweight or obese. All these contribute, and along with the sociocultural drivers, again mentioned by Shalima at the beginning, but also too now in the context of Trinidad and this carnival culture and so on. All of these affect our alcohol exposure pattern, whether we drink spirits, whether we involve with heavy episodic drinking or early onset drinking. These all linked together with biological pathways, acetaldehyde toxicity, liver disease linked to fat, and cardiovascular effects can cause alcohol-related harm, such as alcoholic liver disease, hemorrhagic stroke, myocardial infarction, hepatocellular cancer, alcohol use disorder, intimate partner violence, and injuries. And it's all guided, of course, by how our healthcare system reacts through stigma, late care, underdiagnosis, also the sense of, that this is a normal part of certain cultural groups, right? So I'm almost coming to the close now. How should we use all this information? I think it's useful to think about tailoring our advice to the individual based on their risk factors. So there's some groups I think it might be advisable to tell them it's better you don't drink. If you have a strong family history of cancer, if you're older, obese with a strong family history of cancer or strong family history of breast cancer, if you're a younger woman of reproductive age who's pregnant or is trying to conceive, it's best to stay away not from alcohol altogether. If you're younger than 18, what the research suggests to us is that the earlier you start, the greater your risk for developing an alcohol use disorder, which is what we used to call alcoholism. We don't really use that term again, but becoming basically dependent on alcohol. The evidence suggests if you're Indo-Caribbean, that you should be really very careful about how you expose yourself to alcohol. If you take medicines that interact with alcohol, if you're living with liver disease, pancreatitis, heart conditions, mental health disorder, or past history of alcohol use disorder, you should probably not drink. If you drive or operate machinery or work in a safety-sensitive job, you should be very careful. If you have a strong family history of heart disease and you're over the age of 60, you should keep alcohol intake to a minimum, or better yet, none at all. And if you must start, the later you start, it's better, especially for the young person. The evidence is clear. We shouldn't binge drink. Binge drinking contributes to many of the problems that we see within the region, and the evidence is pointing us, even now very hard evidence is telling us that there's clear evidence of increased risk and mortality in younger males in the Caribbean. So, before we used to go by the evidence based on international studies, but we're getting the studies here now. And I think that we need to educate our young people. We need to educate our families. We need to keep this information alive. For many years, we weren't discussing this. It was it's part of our nature. It's part of our culture. It's part of what we do in the Caribbean. Trinidadian, Caribbean person. All of these things were telling us that the information is telling us that we shouldn't just take those things for granted. So finally, I'd like to invite members of the audience to our 10th Caribbean Alcohol Reduction Day, which is going to be held out online on this coming Thursday. To register, you can scan the QR code, and that will take you to a page to register. And we'll be talking about alcohol now, the health realities we can't ignore. I will be talking about the commercial determinants of health. We'll be talking a little more in depth on that study that we did in Guyana, and some studies done at the UTT and UWI on alcohol use in our young people. And Shalima had mentioned about rum songs. If you'd like to have a free copy of the book, you can scan the QR code here. It'll take you to a site where you can download a free copy. I'm going to leave this slide up for a few minutes. But I'm going to end here, and then we'll have a little time to talk. I see somebody's raised a hand. I'll now hand it back over to Shalima.
Thank you very much,
for your
Dr.
attention.
Maharaj. Extraordinary information. Really, really appreciate all the data and the research that you have been doing. And I agree with you. We absolutely needed to have this research done here in the Caribbean. It has always been a reference to other places. I'm very, very happy to see this. So thank you very much for that.
Thank you.
And at this point in time, I think we really ought to take the questions for you. We do have other speakers, but because it's a Caribbean, we're seeing questions specific to us in the Caribbean. So I think, yes, we can go ahead and take some questions. So for those of you who are not aware, you can go ahead and raise your, you find that in the reactions button at the base of your screen. And Ashley, your hand is up. Go ahead, Ashley. Our chair wants to ask you a question.
It's not actually a question, Professor, but it's actually something that I wanted to add pertaining to what you were talking about in the first and second to last slide in terms of like depression and PTSD. And it's happening with kids at the secondary level, like 16, 17 years old, and they drinking and becoming alcoholics. And when you ask them, what is the reason for it, and you listen to their background, I think it's a way for them to just forget. And it's not that they're just pairing it with medication, they pairing it with marijuana, because it's available anywhere you turn nowadays. So they pair that together with alcohol, and it's like it's a way for them to forget. Because when you listen, and like living in the area that I come from, and you see the kind of lives that these kids have, sometimes it's to say, I kind of don't blame them. I understand where they're coming from, but at the same time, is trying to tell them, you can go and get help. There's people who's willing to listen to you. But then we go back to the idea of stigmatism, and a lot of people who tend to think if you have a mental issue, like mental health issue, it's like, oh, you crazy.
Okay, Ashley, let's get a response from Dr. Maharaj.
Yeah, so in one of the chapters in the book actually reviews a wide section. In fact, it was almost a 30-year review of adolescent research in the region, looking at substance use and looking specifically at alcohol. And what we're seeing is that over that period, there's actually no change, no reduction in alcohol usage among our young people. So we're talking about 40 to 50% of our young people between the age of 13 and 15 admitting to alcohol use in the last month. And that figure has been sustained for almost 3 to 4 decades. So I hear what you're saying, Ashley. And I think we at our last meeting, that I presented, one of our members was talking about, the person from UTT was talking about their research that's basically saying the same thing. So for many years, we didn't have this kind of discussion. We didn't have the data. And I'm hoping now that with the government making some really strong policy decisions, that people at least will start recognizing this is not something we take lightly. There are reasons for it, and that's why I'm giving out this book free. Anybody can take this. The information is now here for you. We have that research from almost 30 years of research around the region. If you take the information, you share it, I think it will help have a huge impact on our populations. Because, when we make our society safe, it makes all of us safe. And so I think that this is the way that we have to move forward. I heard what you said in terms of people using this as a crutch, but we have to find other means to helping ourselves. Thank you.
Agreed. Definitely, we need to find different ways. Thank you very much for that. Kumu Gupta, you have your hand up. Go ahead, please. You need to unmute your mic.
Yeah, hi. Happy Republic Day. So my question is that how much today do you see the impact of the past the alcoholism that came from the colonization, the direct effect, if there is? And also a quick short question is, when you say one drink for women, What size are you talking? Are you talking about an 8-ounce glass or what size?
So it varies. It depends on if it's wine, beer, or spirits. So the standard drink is usually that containing in 10 grams of pure alcohol. So when we talk about it's usually talking like one standard beer, 300 ml, so about 5%, one glass of wine, 100 ml of about 12%, and 1 ounce of spirituous liquor, 40% alcohol. That's usually standard. What happens is it changes from country to country, what's called standard. So we always have to be careful. I think that in terms of the first part of the question, I think that what we've been seeing in Trinidad is this, what we call hegemonic viewpoint, that this has always been part of us. And Shaliman talked about how this has been an integral part of the indentured experience. And I think that experience, because we haven't had a chance to have the information and talk about it, I think it's all still having an impact on us. And you hear about how Trinidadians use alcohol. They don't think about it. There's no discussion. Is this the right decision for me? All right. Is this something that I do because my family of origin does it and nobody else has even talked about it? So our young people are introduced without a sense that this could be harmful, that you could become dependent on this, that you could get harm from this, because it's always been done as part of who we were as a people. And I think that that is the extension of that indentureship period, because it was part of the living in the villages and so on, part of the economic structure that was imposed on us. Yeah. Like, I hope that answers you.
Thank you very much for that. Mr. Dwaraka, I'm glad you're here.
Thank you very much, Halima, and thank you all for a very, very important program. I want to thank the professor for the really up-to-date information that he has shared with us today. I myself have been involved in this field for most of my life, being also a person in recovery. So this is very personal for me. And I still work in that field of rehabilitation and so on. However, I have also done some research in the past, and the question still remains, why Indians drinking so much? In Trinidad, there's a high incidence of alcoholism among East Indians in Trinidad, Guyana, and all of these places. In Ireland, you have a high incidence of alcoholism among the Irish. In North America, you have a high incidence among the native population. Yet, and I mean, we look at indentureship, we look at colonialism, but in Mauritius, for instance, there's a high incidence among the Afro-Mauritian. So it's not so much a genetic thing. I think it's a socioeconomic predisposing factor. So I'd like to hear the professor comments on that.
Yeah, we do know, and that slide that I showed with the different factors do point to the social context for alcohol use. So, if it's a very liberal policies, if it is that everybody is drinking, if you have that carnival atmosphere, so the actual social environment, the political environment, the policy environment, all these things contribute. I think that what we do know about the East Indian population from the genetic studies, and there is a chapter in the book on genetics. And what we concluded at the end of the chapter is there's still a lot of work to be done. The population studied were very small, the total volume of people, a couple thousand people. But it is telling us that there's some special things happening. For example, if an Englishman and a South Asian drink the same amount of alcohol, the South Asian has harm earlier. And that's because many of our South Asian population have a genetic thing that doesn't allow them to metabolize in the same way. So that's one of the things is that when you see, whether you see two people of different races sitting down, they're going to drink the same amount because they're sharing the bottle and no one wants to feel that they're drinking less or more than the other one, right? Because they both put in some money. But unfortunately, what the evidence is suggesting is that the South Asian is having a greater impact on their body. We see it in terms of the liver enzymes, and we see it in terms of the blood cells, how they react to the alcohol. So this is one of the things that we don't talk about, that for some reason our genetics don't allow us to metabolize the alcohol like other races. And so we have to be careful, right? If from the start we know that we are at a disadvantage, we have to be careful. We have a higher fat content. When you have a higher fat content, the same amount of alcohol will cause a greater effect on your brain, because alcohol is water soluble. If you have high fat content, you have less water in your body. That means the amount of water to dissolve the amount of alcohol is less. The alcohol concentration goes up, it causes more harm. So I think that's what the evidence is telling us, that there are genetic things that we need to be careful with. The information is not completely clear at this point. We see it in some of the parts of India. There's even variation within India itself. And we know India is a vast country. So you're going to see that's happening. But what is telling us that something isn't quite as simple as we like it to be. And we then have to see this information and be careful, because there's something that we haven't quite explained. And as you're saying, that we are more prone to it, and therefore we have to be more careful.
Fabulous. Imam Iqbal Haidar, very happy to have you with us. Go ahead, please.
Unmute, please. Yes, unmute.
Imam Haidar, are you unmuted?
Imam, please unmute. He has to do that. We can't do it for him. And he's not unmuting.
All right, maybe we'll give him an opportunity coming down to the end. Dr. Maharaj, I want to thank you very much. Extraordinary information, and thank you very much for accommodating our participants' questions. Ladies and gentlemen, thank you. So I want to bring on our other two speakers now, and let's talk first to Dr. Seshni, or rather, let's hear from Dr. Seshni Mudli first. She is from the UK at the moment, but originally from South Africa. She combines medical expertise with ancestral healing and storytelling, preserving and sharing Gurmitiya narratives rooted in the legacy of South Africa's indentured ancestors. Welcome, Dr. Seshni. You can go ahead for 15 minutes, please.
Thank you. Thank you, Shalima, and thank you for having me. Do you know whether my slides are visible?
Yeah, we'll have that up for you in a minute.
Okay, thank you.
Navin has her slides, I think.
Okay, thank you, Shalima, for inviting me, and for Dr. Kumar and the ICC. May I begin with first wishing everyone a happy India Independence Day to all celebrating, and I hope...
Republic.
Yeah,
Independence.
Yes, and I hope it's a good one for everyone, wherever you're celebrating in the world. I've seen messages already coming in, and it was announced earlier as well. I'm very grateful to be here to talk about the NCDs. And obviously, it's a very hard act to follow from Prof. He's done an amazing presentation. But mine is a bit of a different approach, similar information, but a different approach in terms of mental health. So next slide. So I'm Seshni, and I work, I'm trained as a doctor, and I've trained in psychiatry as well, but I'm currently working as a coach, a well-being coach and mentor. And I also have a background of being interested in ancestral work and diaspora healing. And also, so today my approach to the topic of NCD, which is non-communicable diseases of alcohol, is looking at a holistic view, looking at alcohol as a global driver, and also looking at the diaspora and indentured populations and how they've been disproportionately affected. And then also it's all for educational purposes. If anyone listening does have any issues, please do consult a physician. or if you know someone that needs help. So next slide, please. And as I said, I'll be looking at the topic more from a mental health point of view. Next slide, Navin.
Navin?
Let me call him. I don't know what's happening.
I can continue. So in my next slide, I have a picture of someone drinking in the family in the background. And as you heard the powerful statement by Prof. Miraj and earlier, and also and Ashley mentioned as well about the PTSD. So that's a typical picture you see, when with someone that's drinking. And the reason I actually wanted to do this topic. I mean, Dr. Kumar asked me to do the topic, and I thought it would be really good to talk about this in terms of mental health because it's an addiction. People get alcohol dependent, and as a consequence, we have the NCDs. So that was one reason. And the other reason was a very personal reason. And Dr. Kumar didn't know that, but that's why I was really interested to actually present today. So I'm very grateful for this opportunity. So I would just put this question out there. You don't have to answer, but how many of you know someone affected by alcohol related illness? So this is personal because I knew someone that was very close to me and also had a alcoholic problem. And as a result, when you know someone that's going through it, um, the picture looks like what it looks like in this picture, yeah, and the description that Prof gave. So, and it doesn't just affect the person who's drinking; it also affects the family. So, this was just a personal reflection that I made, and I just wanted to share that with the audience because we all know someone, or one of us may be someone that's been affected by alcohol related illness. So it's something which is more common than we think, and it's important that we talk about it. So, in terms of this, I wanted to look at the research as well of understanding more about the person, how the indentured diaspora is affected holistically as well. And I think Kumu's put a comment about this, so I'll come to answering that. Hopefully, that will come back later on in the presentation. So also alcohol, as you've heard, is the use is shaped by history, culture, and modern lifestyle. They all play a role in NCDs among the indentured diaspora communities. And in the beginning, I just want to leave these three quotes, which may give some hope to people who know someone or someone that's affected is recovery is possible. Hope is stronger than addiction. One day, one choice, one life. Next slide, please. So NCDs, as you heard from Prof, so I won't go too much into detail, but as we know that the NCDs which occur in alcoholism is related to Prof put a picture of 200 NCDs. I actually have that picture at the end of my presentation. I didn't want to alarm everyone that there is so many NCDs as a result of alcohol. So I put these main ones, but actually there is about 200 non-communicable diseases, and these are chronic non-infectious diseases. They have slow progression, they have lifelong impact, and they affect different parts of the organs, as you can see, of the body, the heart, diabetes, you heard of earlier, cancers, and liver disease. So next slide, please. So why is it so important for us to actually have a discussion on this. And that's why I'm so grateful for this topic today, because it is a global health crisis. It causes about 70% of global deaths. So high mortality, high morbidity. It is preventable and modifiable. Alcohol is a modifiable risk factor. Someone put a comment about banning alcohol, I think Paul, in Guyana, and it is preventable, and I can understand why people will want it to be banned, because we can prevent it. The impact on vulnerable populations is higher rates in marginalized and diaspora communities, which will become clearer later on. Economic burden, it costs billions in the healthcare, and there's loss of productivity. The mental health link. Alcohol affects mental health, especially trauma impacted groups. You heard about the PTSD, and empowerment for change. Early education awareness leads to prevention and healthier communities. Next slide, please. So coming to the Indian diaspora, Kumu, you were asking about this, and I did. I mean, the global impact, I'm uncertain as to the global impact, but from the research that I've got into this, as we know, the indentured diaspora period from 1834 to 1917, when Indians had gone as indentured laborers to various parts of the world. So my family went from Gujarat and Tamil Nadu to South Africa. And, likewise, a lot of everyone here is probably a second or third or fourth generation descendant of an indentured that went to Trinidad, Guyana, Fiji, Mauritius, Suriname. So, as part of that, there was a history of alcohol use during and after indentureship. So, it does have an impact. It did have an impact. I think Chan Gupta put a comment about drinking in those periods, and that's probably accurate description. You've heard about the genetic susceptibility already being South Asian. We already have it, that genetic ancestry that makes us more susceptible to NCDs. And then alcohol combined with our lovely diet, a very tasty diet with high salt and high sugar diet, also affects us. And then there's limited access to healthcare in earlier generations. Next slide, please. So yeah, this is just a graphical representation, a map of the different, if you can just visualize it from the first map on the left-hand side, or my left, where there's red and green. So that shows map one is where the indentured went to various parts of the world. So that's the first representation. And then the second one is of alcohol use in the world. So as you can see, where it's darker, the black is where there's more alcohol use. And then obviously it gets different colors as you can see. And then if you look at the third map, is looking at where chronic health diseases and diabetes. This was a World Health one. It's an old one of 2015, but I thought it was interesting to see, if you look at the darker colors, chronic health disease and diabetes, as you heard from Prof. So this is actually the representation of, this was 2015, but obviously 2026, the representation is probably a lot more dispersed. So next slide, please. So, and the Indian diaspora, so we heard there was someone that mentioned about, I think Ken mentioned about offering people drinks, when they come home. And yes, alcohol, there's so many different uses, how we end up having alcohol. So it was during the diaspora, they had homemade alcohol, rum, toddy. I'm sure some of you around here are familiar with these terms. Fermented drinks, or your ancestors that had these drinks. They were linked to plantation life and coping with hard labor. So obviously after hard days labor, they were having alcohol. There was a description by Chan about the having it on a Saturday. There was sold alcohol. There was unregulated and high alcohol content. Obviously, we know for social uses, for any festival, weddings, religious, cultural events, you'll have some alcohol. It's more acceptable among men, but obviously now it's becoming more common amongst young women to have a beer, to have a glass of wine, or cider, and then there's peer pressure and social bonding. And obviously in other modern aspects, in commercial, in work, there's binge drinking, there's also lifestyle and unemployment, and it's easily available. Anywhere you go, there's a 7-Eleven or shops open, it's easily available so people can have alcohol. And then the impact of health, as we're talking about, is the effect on the liver and heart. It raises blood pressure, worsens diabetes, and contributes to the NCD burden. So next slide, please. So again, with the diaspora, there was displacement. So yes, I think how much has it affected the diaspora, the indentured, and then the generations after that is there was an impact because of the displacement, because of the labor, the trauma, and alcohol was used as a coping, and that probably was transferred through generations of coping. So intergenerational patterns. So next slide, please. So yes, so coming to alcohol again, it's a psychoactive substance. So like other substances, drugs, so alcohol is psychoactive. It goes into the bloodstream in this rapid absorption, and it affects the different parts of the body. The concern is that 40% of the adults globally drink, and there isn't a safe level of NCD. You've heard from Prof explaining about the different levels of risk. And obviously the more that you drink. So, and 7% of global deaths are attributed to alcohol and 50% to alcohol liver disease, and that's significant. Next slide, please. So I think Kumo put the question about the units and Prof answered. So usually the amount that we're supposed to have is 14 units per week. And for females, it's 1 unit a day. Males, it's 1 to 2 units. And this is a representation. So it's about 6 glasses of wine or 6 of the pints of beer. So here there's a representation. So for example, 25 moles of a spirit is 1 unit. And then a glass of white wine is 2.3, red wine is 2.3, a pint is 2 units. So, and the alcohol limit is for driving, just to mention that, is 80 grams per 100 ml. So it's about 2 pints. So just in representation, it's good to know the units, and then you can calculate, and you can also advise others how much they're drinking. Next slide, please. I'll try and go through quicker because I'm mindful of the time. So yeah, we've already discussed this about how it affects the brain. I'll come to that. The heart, hypertension, stroke, cardiomyopathy, diabetes, it makes it worse, insulin resistance and obesity, and causes fatty liver, hepatitis, and cirrhosis. And if you look at the Wu diagram there, the 5 main NCD risk is one of them is alcohol, and the others are unhealthy diet, tobacco use, air pollution, and physical inactivity. And then the representation there, as you can see, alcohol affects, as you've heard from Prof, oral cancer, breast cancer, pancreatitis, fertility problems, sexual dysfunction, bowel cancer, type 2 diabetes, liver cancer, heart disease, and brain damage. Next slide, please. So looking at, so I won't go through the full list, but we've already discussed this. I'll move on to the next slide, but that was still the representation of alcohol and how it affects the different parts of the organs. Next slide. Yes, coming to the brain, which is really important, and that's where a lot of the problems start, is it's an addiction. When someone drinks more than they're supposed to, and in psychiatry, they use the Edward and Gross criteria to assess the level of addiction and to then label someone as alcohol dependent. So according to that criteria, someone will be dependent or addicted to alcohol and have an addiction problem. And then, so for me, the 3 main things with alcohol, I mean, there's a lot of mental health problems that occur as a result of alcohol, but it's looking at the addiction itself and the consequences. alcohol being a depressant, as Prof said, is a bidirectional. So the more you drink alcohol, people drink because they're feeling depressed, and then the more they drink, they become more depressed, and it's like a vicious cycle. And you heard from Prof, 20% of people end up committing suicide as a result of that. And the third for me is important, as I started with a personal share, how it impacts on the family, not just the person. So those are the three main things I would say. So it's a central nervous system depressant. It slows brain activity, reduces inhibitions and coordinations and judgments, and can worsen mood, anxiety, and sleep. And the initial buzz of taking alcohol you feel is just initial. And after that, it has a depressant effects, which people don't realize. And that's what actually when problems occur. Next slide, please. So the effects on the brain, it affects the different parts of the brain, the cerebral cortex, the hippocampus, hypothalamus, the medulla, the central nervous system, and cerebellum, which explains a lot of the symptoms. And I've just put the Edward and Gross criteria, and the clinical manifestations is usually when someone craves, they have withdrawal symptoms. Like you may have seen someone that drinks alcohol and you can see the signs in their lips, in the way they move, in the way they walk, in the way they talk, and the physical features. So they'll have anxiety, tremor. It can cause seizures, which can be problematic, and consequences like Korsakoff's and Wernicke's. And a dementia as well, a memory problem as a result of alcohol. It can cause mood instability and cravings. Next slide, please. Hopefully, I'm coming almost to the end of it. For the management, it's a holistic approach, as everyone knows, with alcohol. So it'll be biological, psychological, and social. So looking at medication, looking at the physical health, as you heard from Prof. Psychological, we have and then for medication as well, there's medication for people that are addicted. So if you know someone or someone is experiencing an alcohol dependence, do consult a physician or someone that specializes in it, in alcohol addictions, and get the help because it is treatment for it, and that it does work. So, and they'll put someone on vitamins as well, on thiamine and vitamin B12 as well because of the malnourishment. And if there's any seizures, they'll treat that as well. But looking at the psychological part, obviously psychoeducation, more awareness, looking at the 12-step program. We know there's an Alcoholic Anonymous. Everyone by now should know about this. And having some peer support, spiritual groups as well. Next slide. So it was the same. I was just covering the holistic approach and also alternatives. So I think it's biopsychosocial, looking at the family, looking at how the family can be supported as well. And also, I mean, if you are taking alcohol, take it in moderation, drink responsibly, have regular checkups, get help, and exercise and eat healthy as well. So prevention is better than cure. Know how many units you're supposed to have. What I like about the UK is, and I don't know for other parts in the world, but here when people go out and if they know they're taking alcohol, they don't drive. Majority of the people will take a cab or an Uber. So just be responsible, when you are drinking. Next slide, please. So it's all about awareness and education, looking at the cultural and ancestral reconnection, stigma reduction. I think Ashley spoke about that, and early intervention. Next slide, please. Almost at the end. Yeah, because I'm interested in meditation, mindfulness, and yoga, there is definitely evidence-based to support that doing meditation, mindfulness, and yoga helps reduce craving and alcohol consumption. It also improves emotional regulation and stress management, and it enhances self-awareness and impulse control. There's a lot of studies being done, so do look that up and consider doing meditation yoga or advising that for someone that you know, and mindfulness. But obviously it's not a standalone treatment. It's a holistic approach and combining it with counseling, medical care, and support groups. Next slide, please. Yeah, that's the 200 slide that I said I had, which Prof had as well. I was quite alarmed when I saw that, Prof, this slide when I was preparing. So I put it right at the end because I just thought, at least at the end, maybe then explain that there's actually so many conditions. And someone put a comment that people are drinking alcohol not knowing the risk, but they're drinking and maybe it should be banned. I think that was Paul. So yeah, that's interesting take on that. So the take on that is it's really a difficult one.
Dr. Seshni, I'm sorry, I'm not hearing you right now.
Hello? Hello?
The volume went down a little bit.
Oh, okay.
Go ahead.
Can you hear me?
Yes, go ahead. Oh, it's patchy now. Something is happening.
Can you hear me now?
Yeah, better.
Yes.
Okay, I'll just keep the phone closer. So as I said earlier, this was personal to talk about it, and also on a professional level of dealing with people with alcohol dependence. And I think few people have shared that they knew someone that that is alcohol dependent. So just to say that there is hope for alcohol addictions, and some quotes that I just want to leave, some words of wisdom from people quite wise. Gandhi, we all know, be the change that you wish to see in the world. Nelson Mandela, it always seems impossible until it's done. J.K. Rowling, rock bottom became the solid foundation on which I rebuilt my life. Viktor E. Frankl, when we're no longer able to change a situation, we are challenged to change ourselves. And Desmond Tutu, hope is being able to see that there is light despite all the darkness. Yes, so thank you everyone for listening to my talk. I know I went over time. I did keep a time. I do apologize, and I tried to rush through it. But there's a lot of takeaways from this about alcohol drives NCDs, about prevention starts with awareness, about health disparities in diaspora communities, about healing through community support, early intervention saving lives, and small actions lead to global change. So thank you so much, everyone.
Dr. Seshni, thank you very, very much for your presentation. Excellent information there. And let me apologize to you about restricting your time. Previously, we had 2 speakers, and only yesterday we have our third speaker agreed that he will indeed come on. And I'm sure when you hear him, you will understand why we absolutely needed to give him much more time. So before you go, I just want to ask you what you can tell us, if anything at all, about alcohol consumption among Indo-South African women. And I'm very curious about the extent to which Indo-South African women were consuming alcohol in large quantities, or was it common among them, for example, 2 or 3 generations ago?
That's a very good question. And yes, I think as I explained in the presentation, I think in terms of alcohol consumption, usually, I think the older generations we know, it was more amongst males that were consuming alcohol. But I would say in the last two generations at least, the consumption has increased, and that's also in the Hindu community. So definitely, there is definitely an increase as people are becoming more and more modern, and alcohol is now present in a lot of the cultural activities, functions, celebrations, and in day-to-day life. There's influence of alcohol. They definitely females and South African females, there is a higher consumption rate than there would have been maybe 3 or 4 generations ago.
So have you been seeing, or have you, well, I don't know how long you've moved to the UK, but is there any data available which shows whether or not this has had an impact on their offspring and to what extent?
I don't have the information at hand, but I can have a look and find out. And I'm sure there is definitely an impact on family and on the generations, the younger generations, because we are seeing in South Africa, it's it's becoming more and more prevalent that the younger generation, not just females, but younger males and females are having more alcohol. And that's definitely on the increase as well. But I can have a look at that information for you.
Excellent. We appreciate that. Thank you so much.
Yeah.
So, ladies and gentlemen, at this time, I want to bring on our third presenter. And I'm just going to give you the shortened version of his bio data because it is very extensive. Dr. Ajit Singh Bhadoria is from India. He's an accomplished researcher in the epidemiology of viral hepatitis and liver diseases. He's an additional professor in the Department of Community and Family Medicine at the All India Institute of Medical Sciences in Rishikesh. He holds a visiting professorship at the University of South Wales in the United Kingdom for the period 2023 to 2028 and others as well. Welcome, Dr. Bhadoria.
Thank you so much, Dr. Shalima. I mean, it's a very kind introduction, and I'm really grateful to join this webinar. So, hello everyone. Good morning from India, and a heartfelt namaste to all the friends who are joining from India, the Caribbean, and around the world. And happy Republic Day to all the Indians, and thank you others also for wishing us. So I'm deeply grateful to the Indo-Caribbean Cultural Center's Thought Leaders Forum for inviting me to this 296th online webinar. It's a remarkable milestone that deserves our congratulations. A special thanks to Dr. Mahabir and Dr. Shalima for this opportunity to contribute in this session, which is a very important one. Non-communicable diseases, they're rising, and alcohol is also rising globally also, and we can see that in India also. So today in this session, I'll try to focus on liver diseases, the growing burden, and what are the practical steps so that we can prevent these liver diseases. With alcohol as a key driver, these conditions like viral hepatitis, fatty liver, they affect millions. But the good news is that we can prevent all these diseases through simple lifestyle changes. So I'll just share my slides and then we can go through. So I'll start initially with telling you all about the liver first, so that you should know this organ, this I'll say very strong and very useful organ of our body. I hope my slides are visible, Dr. Shalima.
Yes, it is. Thank you.
So as mentioned, so I'll be talking about liver first, then I'll tell you about what are the common liver functions, and then what are the common liver problems which happens, common liver diseases. And then we'll go to understand about the preventive aspects or preventive strategies for these liver diseases. So we should understand that liver is well placed in our body by the Almighty in the right upper quadrant, well protected by the right rib cage. The weight of this organ is 1.5 kg, and it is the largest intra-abdominal organ. If you see the blood supply, that gives us a hint about the importance which is given by God or given by the body to this organ. So out of the 1.5 liters per minute of the blood supply, the 25% of the cardiac output from the heart goes directly to this organ. And that's also not sufficient. This is only 1/3 which is coming from heart. 2/3 of the blood is coming from the intestine. So whatever we eat, it goes first into the liver, and then liver decides what is good for us. It then goes in the body, and the toxins or something which is bad for our body is taken care by the liver. Liver tries to break it down, and sometime in that process, it causes damage also. So normally organs, they have few functions, but when we talk about the functions of liver, it's a long list of functions. It's around 500 functions. So I'm not going into detail, but you should be knowing about the most important role of liver is detoxification. So we were talking about alcohol in last two talks. So drugs, alcohols, everything is broken down into the liver, and liver tries to take care of all other toxins which comes into our body, which can be through preservatives, in the packaged food, which can be insecticides or fruit ripeners. So there are many chemicals which are increasingly coming into our body through the changing lifestyles, through the changing eating habits. Then the other important role is the metabolism of not only thyroid hormones, but also fat, protein, immune system. So protein, liver is also involved in many synthesis of many important proteins like albumin, globulin, which are really important to take care of our many functions. So whenever there is any loss to these functions, we get signs and symptoms. Liver is a very strong organ. We don't see any sign and symptoms till the 70 to 80% damage is occurred. So liver is also important, very important for maintaining our blood glucose levels also. So whenever you are fasting, our blood glucose levels are maintained by the liver. If you're eating, then at that time also the blood glucose level is maintained by the liver. So liver and diabetes, they also have a very strong association. And we all know that diabetes prevalence is also increasing. With diabetes prevalence, fatty liver disease is increasing, and that's why you're seeing more liver diseases also, more cirrhosis, more liver cancer. So when we talk about what can cause damage to liver, so we all know about alcohol. Other than alcohol, now the most important factor is excess of fat in our body, which is because of our sedentary lifestyle, poor eating habits, and not doing physical activity regularly. And then comes infectious causes also, like hepatitis A, B, C, D, E. And out of these 5 very important viruses which causes viral hepatitis, B and C, they mainly causes chronic liver diseases, chronic infection leading to cirrhosis and liver cancer. Hepatitis A and hepatitis E mainly causes acute hepatitis, and sometimes ending up into acute liver failure also. So transmission of hepatitis A and E is through contaminated water and contaminated food. We call it as fecal-oral transmission, and this leads to acute hepatitis and can end up into acute liver failure also. With improvement in hygiene and sanitation, as we are seeing in India or other developing countries, when there is improvement in hygiene and sanitation, you don't get exposure to hepatitis A virus or hepatitis E virus early in the age. So that means your adolescents, your young adults, they are susceptible to these viruses. And when they move out after the school, when they start traveling, they get exposed to hepatitis A and E, and there is high chance of getting a symptomatic and a severe liver disease because of hepatitis A and hepatitis E. So fecal-oral transmission, this is just a pictorial diagram. It can be transmitted through close contacts also, through contaminated food and contaminated water. And if we talk about prevention, it's very easy, very simple. Safe water supplies. I know that developing countries, many areas still they're struggling to get safe water supply, but that's the only option to prevent these fecal-oral transmission. Then personal hygiene, like regular hand washing practices, safe food, washing the food before we use it. And we can also, the street food eating habits is also increasing with time. People, they're now not comfortable getting more time in cooking in kitchen. They always try to get the food from online methods or going out and eating outside. So when you eat outside, there is high chance of getting these infections, because sometimes if the hygiene or sanitation is not taken care of. For hepatitis A, we have a very good vaccine which can be used for not only preventing outbreaks but also taking care of those who are susceptible. And now hepatitis E vaccine is also recently introduced in India in August 2025. So for both infections, now we have vaccines available. So transmission of hepatitis B and hepatitis C and hepatitis D is similar to HIV. And those who understand HIV, as we know that HIV is there since last many decades. We also have a program in India on HIV. Now recently a program is introduced for viral hepatitis also. So transmission of hepatitis B, hepatitis C, and hepatitis D is because of unsafe blood or unsafe injection practices. It can be through is more common in some high risk groups who are involved in sexual practices, who are involved in people who inject drugs, and sometimes also to those patients who get multiple blood transfusions. So sexual perinatal transmission and inapparent horizontal transmission spreads these infections. When we talk about prevention, so we have very good vaccine for hepatitis B, which can prevent effectively 98% of those who get hepatitis B vaccine. In India, we have this vaccine in universal immunization program, and hepatitis B birth dose is also recently introduced, which says that we have to give this vaccine within 24 hours of birth, and this can prevent mother to child transmission. And then safe blood, safe injection practices, universal precautions, safe sex, test and treat for hepatitis C is important, because now we have very good drugs for hepatitis C. So when we talk about hepatitis A to hepatitis E, all are preventable. And there are different methods, but we can prevent all these infections. And these infections, we know they can ultimately end up into cirrhosis and liver cancer. And then liver transplant is the only option, because when liver damages to that stage, it's always irreversible. Alcohol, we have talked so much about alcohol in last I'll say 1 hour. So it's the most common cause of cirrhosis and end-stage liver disease in India also. It is showing a rising trend of alcohol consumption, as was discussed with by the last speakers also. If you see Indian data also, we are seeing increase in annual consumption of alcohol, and even you can see the current drinkers, they are now almost double. Earlier it was 15%, now it's 30%. And this rising increase in alcohol consumption in adults, I'll say more in females also nowadays in India also. And this is something which is really alarming, and we need to think about it. If we talk about safe level, there is no safe level. According to WHO, no level of alcohol consumption is safe for our health. So that should be the clear-cut message, that there should be no alcohol policy. Whenever you take alcohol, you are always at higher chance of getting the long list of 200 non-communicable diseases. So these are few studies which we did in India, which documented that if you have bad metabolic health, or if you have personal or family history of metabolic diseases, you are at higher chance of getting damage because of alcohol. So this clearly mentions that if you have a family person with diabetes, or if you yourself has diabetes, obesity, fatty liver, dyslipidemia, and other metabolic diseases, there is higher chance that you get alcoholic liver disease also if you consume alcohol. And now in India, we have a non-communicable disease program, which is targeting not only non-alcoholic fatty liver disease, but also alcoholic liver disease. So as I was mentioning, that the extra fat in the body causes a lot of damage to liver, initially starting with asymptomatic fatty liver, and then may end up into non-alcoholic steatohepatitis. That means inflammation of liver because of irritation which is caused by the fat, and then can end up into cirrhosis and liver cancer also. So excess fat because of poor lifestyle, because of sedentary lifestyle, excess fat in the body or obesity is increasing not only in India but also globally. So how common is fatty liver disease? If I talk only about India, it is around 38%. That means at least around 1 out of 3 person is fatty liver. If you'll screen 100 people, you'll find fatty liver in around 38 individuals. So this is very high as compared to other non-communicable diseases. And childhood obesity, we know that it is increasing because of same reasons. Kids, they are more into the screen time is more, they are more into mobiles, online games, they're not going outside playing games, and they're also more into junk food eating. And in India, the prevalence of non-alcoholic fatty liver disease is very alarming. It is 35%. And we all understand these children who have childhood obesity, who have fat in liver early in the life, they end up into getting more non-communicable diseases during their adult life. So what causes fatty liver? As mentioned earlier, also, it is because of lifestyle, metabolic risk factors, and genetic and other factors also, which can be easily tested by just asking the family history. So lifestyle factor includes sedentary lifestyle when you don't exercise regularly, dietary factors, which includes like sometimes snacking, eating more of fast food, the junk food. Junk food is the food which is more rich in calories and poor in vitamins and minerals. And there is also, ultra processed food, which is coming up where you try to extract the nutrients from the food. So the we are not eating that good quantity and both quality of food which we were taking earlier, and this saturated fat, trans fat, sweetened beverages like cold drink, processed food, ultra processed food, energy dense food, high glycemic index food, they are leading to more fat in the body and also accumulation of more fat in the liver also. So as mentioned earlier, there is a very strong relationship between liver disease and non-communicable diseases. Diabetes leads to fatty liver leads to diabetes. There are many studies which documents there is a strong relationship between all these non-communicable diseases like obesity, diabetes, hypertension, dyslipidemia, and fatty liver. And we have to manage these conditions also when a person is suffering from fatty liver to get better outcomes. Obesity is almost all obese people, they have fatty liver. There is some group of people who exercise regularly, they're obese because of some family reasons, and they only you can find no fat in the liver. We call them metabolically healthy obese, but the proportion is less. Even fat is high in non-obese also. We call them lean NASH. That is those who have BMI less than 18.5, but still they have fat in the liver because of unhealthy lifestyle or because of a strong family history. So obesity is, the chances of fatty liver is tripled or even 4 times as compared to general population. How to prevent it? This is something which is very much preventable by our changing lifestyle only. So these are the lifestyle choices which directly influence our liver health. So we have to just exercise regularly. We have to take care of our diet. So when you talk about diet, nutrition and diet is very important, not only for fatty liver, it is also very important for non-communicable diseases also. So we have to move from ultra processed food to whole grain food, moving more towards fruits and vegetables daily, nuts, seeds, legumes, pulses should be included daily in our lifestyle. WHO recommends it should be like 3 to 4 times, or 4 servings in a day. Fish, poultry, those who eat non-veg, reduce red meat as much as possible, and also go for fermented dairy products. Coffee, there is very good enough data that 2 to 3 cups of coffee always is good for liver. And we should avoid the junk food, soft drinks, high salt food, high fat and sugar foods. And always whole fruit is better than the juice. WHO recommends that we should exercise at least for 30 minutes in a day, at least for 150 minutes in a week to be fit. So there are many studies which says that exercise, irrespective of weight loss, is good for health and good for liver health also. So those who sometimes patients comes to you and say that I'm exercising regularly, but I am not losing weight. We should tell them that should not be your goal. Your goal should be regular exercise, regular physical activity, not weight loss, if it's not happening. So this is my second last slide, which talks about holistic healthy lifestyle. These are the pictures which we use whenever we go for health education awareness programs in either school or in the community, telling them that there should be no smoke, no alcohol policy, get good sleep, stay away from stress, do meditation as mentioned by the earlier speaker also, reduce your screen time, go out and play, and eat healthy if you want to stay healthy. So health of the people should be in the hands of the people only. They should understand it, and then they should adopt these healthy lifestyles. So overall take-home messages is that all liver diseases, you talk about viral hepatitis, fatty liver, or alcoholic liver disease, they are preventable. We have to just move from sedentary lifestyle to active lifestyle, move from high calorie diet to low calorie diet, and more rich in fruits and vegetables and whole grains. And early stage non-alcoholic fatty liver disease is reversible. That's something which we should tell our people, that if you have fatty liver, that's a red flag sign for getting a serious liver disease. But the good thing is that it is purely 100% reversible. But if you go into NASH or cirrhosis or liver cancer, then it's irreversible, and you end up into thinking about a liver transplant. So healthy lifestyles, they are the strongest prevention strategy for liver diseases. For hepatitis A and E, hygiene and vaccination. And for hepatitis B, C, D, it is safe sex, safe blood, and vaccination for hepatitis B. So our life or our health or our liver health is in our hand, and we should adopt healthy lifestyle so that we can get rid of not only alcoholic liver disease, but also from fatty liver disease or viral hepatitis. Whenever these diseases, they come together, they increase the chance of more liver damage. Like if a person who have fatty liver drinks alcohol, more damage to liver. If a person who has hepatitis B or hepatitis C drinks alcohol, causes more damage to liver. So thank you so much. I'll be happy to take questions if there are any.
Thank you very much, Dr. Ajit. Extraordinary presentation as well. I see two participants with their hands up, and I will welcome any of the other participants. Please go ahead, raise your electronic hand so that we can take your questions also. And Navin or Dr. Mahabir, could you please check YouTube and let me know if there are any questions there? Thank you. Before I bring a member of the audience, I just want you to clarify one thing for me, please, Dr. Ajit. In terms of treatment of fatty liver disease, is it the same irrespective of it being alcoholic or non-alcoholic?
Yes, if we talk about fatty liver, normally if you have fat in liver because of any reason, there is no treatment, and there should be no treatment. Only lifestyle modification is important. But when the liver enzymes, they start rising, and because of steatohepatitis, when there is inflammation in the liver cells, ALT is high. At that time, there are some drugs which are beneficial, like vitamin E, pioglitazone. There is recently introduced drugs, saroglitazar. So there are few drugs which works in this period of time. Even these drugs are not useful if you have cirrhosis developed, which is irreversible. So during the whole spectrum of liver diseases, these drugs, they only work when in between part, when there is it's not that serious, and it's only steatosis.
And can you please tell us what are some of the symptoms of fatty liver disease?
So fatty liver disease, like other liver diseases, is mostly asymptomatic. But yes, the simplest form of symptoms can be like sometimes heaviness on the right side of where the liver is placed. You can feel, some heaviness over there. Sometimes there is dyspepsia. People, they comes with like bloating. So they are like non-specific symptoms for liver disease, which more of look like some GI disturbance, not specific to liver.
So someone with a distended stomach, or they feel like they're always bloating and so on, and they feel that they are putting on weight, may not necessarily be becoming overweight, but it may be fatty liver disease.
Yes. So whenever there is that such kind of non-specific symptoms, they should also get their liver scan done, which can be an ultrasound or which can be a fibroscan.
Fibroscan. Okay, great. Thank you for that. Kumu, go ahead with your question, please.
Yeah, so my question is that when you go to your doctor's office, which indicator will tell you that you could have a fatty liver, or reversely, which test should you ask your doctor to do to find out whether you have a fatty liver?
So that's a very good question, because most of the time, as I mentioned earlier, it's asymptomatic. So and the prevalence is also very high. 40% they have fatty liver. So whenever you are visiting your doctor, and if you want to get your liver scan done, so as mentioned earlier, simplest way is ultrasound. Ultrasound gives you the grading of fatty liver in your liver. And there is one machine which is known as FibroScan or FibroTouch, which is a transient elastography machine, which gives you two values. One is about how much amount of fat is there in your liver, and if is the liver damaged and now stiff also. So we call it as LSM, liver stiffness measurement. So you can get these two values from transit elastography machine, but it is costly, so it's not that commonly available in the hospitals. But these two tests can give you help you to know about whether you have fatty liver or not. But if you want to go for simple test also, even a liver function test with high ALT can give you a hint that yes, there is something which is not good with liver, and then you can go for liver scan.
Thank you for that. Chand, go ahead, please.
Since Dr. Badora has mentioned about street food, and that is something which is very common in most of the countries, and since India has a large population, so there's much more compared to other tiny countries like Fiji. So my question is, with the street food, some of them are very unhealthy, prepared in a very unhealthy way, using refined oil, and they are sold out in the open, not covered. So lots of environmental dust and pollution and everything goes into the food. So what can any country do to balance that with what Dr. Badora has suggested, with a healthy lifestyle and eating wholesome and whole grain, and another doctor has mentioned like rainbow food. So how can this the country and the people on the street level bring a balance into this to make sure that the population is not being fed junk?
Thank you, Chand. I think that's a very good question, and it's something which is very challenging also, not only for us, but also for policymakers, how to manage it, because people, they need food, they need quick food, they need cheap food. So that's why these street vendors, they are increasing in number in India and other developing countries also. So what we can do is we can just try to regularize these food vendors, where we can do their trainings also for hygiene and sanitation, where we can also provide them education awareness also about how fecal-oral transmitted diseases can happen to the community or to their clients if they are doing that. And even putting some checks also, like whether they are following all those regulations or not. Like in India, we have food inspectors who regularly visit these shops. But yes, still there are many challenges. But to prevent both fecal-oral infections and also, as you have mentioned, junk food or heating the oil regularly, which increases the chances of more harm than any benefit to the people. So I think we need to train them, educate them, and there should be a system in place by the government which can regularize these shops and these food vendors.
Have they brought these vendors under the Swasth Bharat campaign?
So Swachh Bharat campaign is like mainly about sanitation and hygiene, but no, they are not under that particular program. But yes, we have another program in India which called Eat Right India movement. In Eat Right India movement, we are not only educating community, but also we are educating these small vendors also to take care of the good quality food and try to provide healthy food to the clients instead of transmitting any disease.
And how about the Ayushman Bharat campaign?
So Ayushman Bharat campaign is an umbrella program which is very broad, and it includes two main components. One is Pradhan Mantri Jan Arogya Yojana, which is like health insurance for those who get secondary or tertiary care. And then we have comprehensive primary health care through 1.5 lakh health and wellness centers, which is for primary care. But there are some components which is covered by Ayushman also, but mainly Eat Right India campaign, Fit India campaign, they are taking care of such activities.
Right. Thank you so much.
Thank you for raising those campaigns, Chand. I wanted to ask a question. Doctor, you said earlier, correct me if I'm wrong, that there is an NCD program in India. Would you mind just outlining for us, please, what are some of those measures under the program?
Yes. So we have a program for non-communicable diseases. It's there in India from last 2 decades, but now non-alcoholic fatty liver disease is also introduced in 2019 into this program, so that along with diabetes, hypertension, and other non-communicable diseases. Now, fatty liver disease is also being taken care by this program, which says that our ASHA workers or A&M workers, they have to fill one form. We call it as community-based assessment checklist form, which asks 6 simple questions about like age, alcohol, physical activity, family history, then waist circumference, and then smoking, and then we score them. If the score is more than 4, then they are at high risk for non-communicable diseases, and then they are referred to medical officer for further management. And in this program, they are targeting to have one transient elastography machine per district. We have 760 districts in the country, so at least in one district there should be one machine which can at least give accurate results about fatty liver and liver stiffness in that community.
Are those elastography machines made in India?
We don't have any Indian brand right now. We are having one from China and one from EcoSense, which is also some foreign company, but not from India.
Probably Europe.
May I
Yes.
ask another question?
Thank you.
Yes,
Chan,
Chan.
hold on, please. We've had
Okay.
Imam Iqbal Haidar waiting for quite some time, and I want to thank you very much for your patience. Imam Haidar, go ahead, please. Unmute.
He has to unmute. Unmute Imam, please.
Imam Haidar? Still nothing.
He unmuted for a second and he muted back.
Imam Haidar, go ahead, please. Just unmute again.
Are you
You're
hearing
unmuted
me?
now. Yes,
No,
we're
we
hearing
are
you now.
hearing you. Yes. Thank you, Navin.
The presentations have been excellent. My question really is based more on alcoholism. Recently, the Archbishop of Port of Spain had indicated in an interview that social media was more addictive than alcohol. It gave me the impression that alcohol was being played down.
Yes.
My question is there any data or research which has associated religion with alcoholism, or the influence or non-influence of alcoholism?
Dr. Bedoria, you want to try it?
I mean, as much as I know, whenever we do research, we also ask for religion also. There are few religions who say strict no to alcohol. But I mean, if I'll say a good high quality research looking out into religion wise, consumption of alcohol is not done. So, I mean, there are people in all religions who take alcohol, irrespective of, irrespective of whatever is practiced in that religion. But others can, tell us if they have any experience in that research.
Okay, thank you. So let me just ask the same question to Dr. Seshni. Dr. Seshni, can you shed some light?
Yes, thank you. That was a great presentation, Ajit. And yes, thank you, Iqbal, for your question. I found it very interesting, actually. So the first thing you said was about addiction and social media addiction. Actually, I have had completed a write-up on social media addiction. So that's quite interesting that the point you said, what you heard was that social media addiction was taking over alcohol addiction. And obviously, as you can see from the 3 presentations today, alcohol dependence and alcoholism is still very much prevalent, and a high morbidity and high mortality. And obviously, the communicable diseases from it is obviously quite prevalent as well. But similarly, in terms of it, I think probably why they equated it was to do with the addiction. Like any addiction, you get with social media addictions, the dopamine that's released and giving pleasure, and that's why the addiction continues and it becomes so severe. And obviously, we'll be seeing more of that. But in terms of alcoholism, yes, it is still an addiction, but I wouldn't say that it's been taken over by social media addiction. So I hope that answers the first one. And then the second one, yes, it is interesting as well, that question that you've raised about religion, because when I was preparing my presentation, I was also conscious of this one factor, that whether religion actually was a protective factor for obviously alcoholism, because as Dr. Jeet said, certain religions, like certain Muslims, it's haram to take alcohol. So, but I do know some Muslims do drink. And then likewise with other religions, if they're quite strict with Hinduism or maybe Jainism, and with like obviously with gurus and priests, and those that are obviously quite spiritually evolved, they wouldn't take any alcohol. So yes, I think I haven't seen specific studies, but I'm sure there is. But definitely, I think religion will play a role in terms of our morals and values, and how religion affects us in terms of, if it's Hinduism you're following, that there's some part of your belief that you can't take alcohol. And but obviously everyone's religion is different, everyone's belief system is different. And yes, so obviously at the end of the day, people will sometimes, even if religion says no, people will still drink alcohol. But I think that's quite interesting as well, and I'd also like to see the figures of that. So thank you for that.
Thank you. Thank you very much, Dr. Seshni. Dr. Rohan, can you please tell us whether here in Trinidad and Tobago, when the assessments are being done, or when the preliminary information is being taken in hospital, whether religion is one of the fields that is there, so that we can kind of draw some correlation between religion and diseases?
So I was listening to this. We had, I went back to look at some of the reports that we had created out of the National Alcohol Survey of Households in Trinidad and Tobago. We did collect the data, but unfortunately, I'm not seeing the analysis and what it was and what it had said. I'm not quite sure why not. And maybe an opportunity to go back and look at that data again specifically, as people are interested. I know that we had broken down the categories, but most of the papers that we published, some reason the information was left out. So I'll have to go back and have a look at that for you. Maybe have an opportunity for a future presentation.
Yeah, excellent. Thank you very much. Dr. Mahabir, you had a question.
Well, more observation. When you look in Trinidad and Tobago, when you look at the rum shops, the bars, places that sell alcoholic drinks, very few Muslims own them. And when you look at the groceries, the supermarkets owned by Muslims, they hardly, maybe don't ever sell alcohol. Having said that, it doesn't mean to say that Muslims are not drinkers. That's it.
Yeah, point taken. Thank you. And I think that is perhaps why Imam Iqbal is raising the question, because then it brings about a whole other issue. And Dr. Seshni, I think you'll agree with me on this. Within the Jamaat, you may have questions to address. This is possibly a topic that has to be raised. But of course, the data has to provide for that, because an Imam, I don't think, would go on stand up and start talking about this. Before I bring on Mr. Dwarkal, let me hear from Ashley. Ashley, your question, please.
Right. So my question is specifically for Dr. Ajit. He kind of brought up something specific in terms of children and obesity. And I think in terms of that, we need to look more at the parents. Parents are responsible for their kids and what they eat and what they do. So how do, and this is not just, specific to as a particular country, but this is worldwide. It's happening worldwide, right? So how do we get parents to understand that, go outside and exercise instead of putting a tablet in their hand, put a bicycle, or like how we used to do long ago, I didn't grow up on a tablet. I grew up on riding bike outside. So, and those are the things that keep you healthy as a child. So how do we get parents to understand? How do we get it out to them that, listen, what you are doing is wrong?
Okay.
Right. So that's a very good concern. I'll say it's very difficult make such kind of changes which is happening with time. So I understand that now the kids, they're not going outside, not playing that much, they're also I think what message we can give to parents is, first off, they all should be educated about rising burden of childhood obesity, fatty liver, and these kids now, they are at high risk of getting diabetes, hypertension, and other metabolic diseases in future, and that also at early age. So first we have to make them understand this part, and then we try to tell them that they have to practice what they want their kids to do. If the parents are also on mobile laptop all the time, you can't ask your children to do something which is different. So parents should go out and start playing with the kids. They should give more time outside, giving taking out from the routine and playing with them by themselves, generating interest again back to in bicycling or in playing games outside, outdoor. So first is awareness, making them aware about the condition, and second is making them understand that this is really important and this is something which is very alarming, and they should have it's their responsibility. Other than parents' responsibility, I'll say it's responsibility of teachers in schools also, because kids, they also spend a lot of time in schools. So school education programs involving teachers in giving good messages that also plays a very important role. Kids, they come back to home sometimes getting sharing the messages of the teachers and asking the parents to follow what teachers want them to do. So I think both school and home and house, they should do some changes in their routine so that we can get rid of this childhood obesity.
Thank you for that. I see Dr. Rohan's hand is up. He may want to add something. Dr. Rohan, go ahead, please.
Yes. Thank you for those comments, everyone. It's been something that we've been looking at. We've just, one of the last studies we've been doing in Eastern Caribbean, one of the factors we've identified is the safety of the environment, how people feel about the environment they live in. And one of the challenges we've had in the Caribbean with the large levels of violence and guns and so on, and gangs, is that people don't feel safe taking their kids outside. And so it is an issue, it's a policy issue, it's a government issue, it's a national security issue that parents feel much more comfortable having their kids sitting down. So we need to not only say that this is important, we also need to create spaces and environments. I know they've tried, looking at the sugar sweetened beverages in the schools. We've had some work being done on that to try to make sure that the kids are not drinking the heavy soft drinks and so on. But that's been a challenge because the kids are now getting it from home. So the school is trying to do something, but the family, because of convenience, are just putting it into the lunch kit. So a lot of work needs to be done. It has to be a lot of public education, has to be creating environments where the healthy food, so that one of the challenges is when people have 3 and 4 jobs, is that whatever is quickest, they will eat. But if you only have fast foods being provided rather than better quality foods, or having some sort of system whereby better quality foods, whole foods and fresh fruits and vegetables are made available, people are not going to buy it. They're going to go quickly to the more inexpensive fatty products. So a lot of it has to do with the environment in which we find ourselves, certainly in the developing world. This is a real challenge.
Thank you very much for that. Mr. Ramnaresh Dwarka, you've been waiting patiently. Please unmute. You're still muted. Yes, go ahead, please.
Yeah, in the interest of time, Shalima, I will just make a brief comment here because the alcoholic is a very rare cohort now. What you're seeing, alcohol has become like a gateway to the other drugs, the marijuana and the cocaine and all the designer drugs. So it's very rare you're going to get a person who's a pure alcoholic. And even so, it is very difficult to quantify because anyone presenting at a hospital is not diagnosed as alcoholic. They might be diagnosed for a broken arm, a broken leg, traffic accident, whatever. And the alcoholism is very, very hidden. So I wanted to say that I had raised a question in the column, the question of advertising versus counter-advertising. Because in spite of all these programs, and I do other programs as well, the fact is how much of a dent we can make, compete against the producers, the rum producers, and the people who marketing, the kind of revenue they put into advertising. I know and the government is not really supporting us there, I must say, in counter advertising. And another question is whether the revenue we're deriving from the alcohol sale and all of that can really compensate for the social cost that is involved. And maybe this is something we need to look at in the future.
Certainly. I see Dr. Rohan Sanders up. Go ahead, please.
Right. So sorry to come back again, but just two things, Shalima. Unfortunately, I've just been able to find these surveys that were done regionally, the STEPS risk factor surveys, and religion was not collected. So these are the largest studies we've done in the Caribbean. We've just finished ours in Trinidad 2024. That data on religion was not collected. So we can't see, for example, if some of those religions that promote a sort of vegetarian diet, the Seventh-day Adventists, for example, the low alcohol diet, such as the Muslim faith, is that we can't see if that's having an impact. So unfortunately, maybe it's something that we have to look at in the future. And coming back again to that question, Mr. Dwarika, is that's where we need government policy. Some of these things can't be done at the individual level. We need to get our governments to really look at this, in terms of how do we combat the alcohol industry and large amounts of money that's being put into this. They have to protect us. They know that this is what I'll be talking about this on Thursday, the commercial determinants of health. There are things outside of our power that determines how we make choices. When the alcohol industry creates this brand that tells you that this is the best thing that's ever happened, the walking man that goes on for the Johnny Walker and so on, people buy into this because that's a sign of success. And we are being bombarded, our young people are bombarded by this, and they can't make decisions about it. You see FIFA with the red band, with the green band with the red star. We all know what that is. You don't even have to say the word again, but you know it's selling beer. And our young people are exposed to this. They exposed it in the media, on the internet. We may not want our kids to do it, but it's happening. It's coming to them on Facebook and all these other things. So this is where the organizations that I work with, the Global Alcohol Policy Alliance, is trying to work at the highest level, the World Health Organization and so on, to try to change how advertisements and so on are put out. And that has to happen at the highest level. It's not going to happen. We can't combat the alcohol industry. The income from it is far supersedes the budgets of many of our countries. So we can't fight these people. They've taken what's happening in places like Paraguay. They've taken tobacco, takes the government to court because they're trying to do things to try to protect the population. So this is where we need enlightened government. We need to have government that's not receiving money from these large organizations, because then they have to come back around and abide by the rules. So if you're interested, that talk on Thursday is going to give you some of the ideas what's happening in the Caribbean and some of the challenges we have in Latin America and the Caribbean about the commercial determinants of health. Anyway, I've talked enough. Thank you very much for listening.
Thank you. So Dr. Rohan, you just reminded me of something I was looking at on the news. They do those talk to the man in the street in response to something that the government has done. So when the government had announced recently that they were increasing, was it in December, that they were increasing the taxes on alcohol? A man in the street said the government is taking away our only pleasure, something that we totally enjoy. The government is trying to take that away. So the government is getting licks anyhow you take it. And then we have now the leader of the opposition, the local opposition, who is going to lead a protest, or has announced that she's going to lead a protest because she wants to have the prices on alcohol decreased. So she is now fighting the government on a positive move that they've made to control this thing. So there's a lot that can be said.
Yeah, our second national study showed that almost 80% of our population will accept raising things like taxes on alcohol. This was done maybe less than 10 years ago. So large amounts of our populations are fed up. We've had a lot of experiences, and almost everyone here knows somebody, a friend, a family, a relative, a neighbor who suffered the consequences. So I think that they're not recognizing that people have felt the pain of alcohol for many years. When we've done our surveys, people have said, why are they taking so long to do this? Right? People are interested in change. And I think that is not, they're not understanding the true feeling about the public. Yes, there are going to always be a few protesters, but many people are happy for these changes. So I don't know. We'll see.
Yeah. So let's see what happens. Thank you. Dr. Seshni has a hand up.
Yeah, just quickly, Shalima, Mr. Dwarika, he asked two important things. He made the point. The advertising, I was actually thinking when I was preparing my slides that, like they have the campaigns for cigarette smoking, they have the advertising where they actually put a picture of the lung and obviously explaining that smoking can kill and, it's quite aggressive, the advertising. So I was thinking maybe that's something that they should be doing with alcohol, something on the bottle or some advertising sort of in that form. But I don't know what everyone else thinks. And then the second point Mr. Dwarika made, which was really important actually, was that the alcohol use, usually they'll have a comorbid substance misuse like cannabis, cocaine, ecstasy, heroin. And also he said that there's always an underlying sometimes it's hidden. So the person might go in with an orthopedic fracture, or they might go in with some other, with another medical condition, and then it's not been picked up that yes, that person has alcohol dependence. So I think that is those two things he raised was quite important. So thank you for that. Yeah, thanks.
Thank you. Dr. Rohan.
Yes, when the public health people have been able to put messages on bottles, the messages have to have a certain size. For example, if you go to the alcohol Angostura, I believe, is having labels to describe their product, but you can't read it. They're very tiny. So the size has to be important. It has to be at least 3 to 4 centimeters in diameter. They've run this experiment in Canada where they show that if you have the labels on the bottles, people will think twice and sales will be reduced, especially among, for example, among young women of reproductive age who may recognize, hey, you know what, I may have sex tonight. Let me be careful. I'm not going to drink. So it has an impact because it makes people at the time of use become aware of the risk. And so, there is some, but you know what? The alcohol industry fights them back and they go and they take the state public health people to court, threaten them with huge fines and legal risk. So, this is where governments have to really make a real considered effort to start protecting populations, and all the international rules and regulations, all the different conventions of United Nations are there already. The power is there. The legal precedents have been set for us to make these changes. But the alcohol industry is so powerful that they're pushing back, And so this, hopefully over the next few years, we'll see some changes. Our meeting in April this year in Rio on the Global Alcohol Policy Alliance is looking at the commercial determinants of health and how governments and organizations can work towards reducing the impact of the alcohol industry. And we look forward to seeing what sort of changes come out of that.
The commercial determinants of health. I'm making a note of that. Thank you very much. Dr. Ajit, we are now at 5:11 here, so we are 11 minutes past our time. It's very, very late for you in India, I know. And I want to thank you very much for being here, having the patience despite your very, very long day. For those of you who don't know, Dr. Ajit probably has not slept in about 24 hours, and yet he's here with us. So I want to thank you so much for that sacrifice. One last question before we let you go. In UP, Bihar, and Tamil Nadu, for example, can you tell us whether or not there has been significantly more cases of cirrhosis, alcoholic liver disease, and so on?
I don't think I have not seen such data which specifically mentions about more cases in these states, because I don't think such kind of study has been done. Because when we talk about liver diseases, we have very few important big hospitals who take care of these liver diseases, and then the people from all states, they move to those centers. So I mean, there are few states where alcohol is banned. There is no alcohol policy like in Gujarat, Bihar, but still, because of when there is no alcohol available, they find out some illegal ways to get that alcohol in those states. So in India also, as mentioned by Dr. Rohan and other speakers, there's a very huge push from alcohol industry of not getting such kind of messages on bottles or such kind of policies which can reduce the sale. So same for India also, we are still struggling how to reduce that alcohol consumption. As I've shown in my data also, it's increasing. Currently, it is increasing, and that is the trend which I am seeing in the coming few years also. So yes, the overall, if you see the studies, not state specific, the alcoholic liver diseases and non-alcoholic fatty liver disease related cirrhosis and liver cancers, they are showing a rising trend. Hepatitis B and hepatitis C, both, they are showing a declining trend with time.
Yeah. Thank you very much for clarifying that. Ladies and gentlemen, I want to say a very special thank you to our three presenters today, Dr. Rohan Maharaj, Dr. Seshni Rensburg, and Dr. Ajit Badoria. We really appreciate it. What we've learned from them today is significant. NCDs arising from alcoholism represent a major but often under-recognized public health burden. Prolonged and excessive alcohol use significantly increases the risk of cardiovascular diseases, liver cirrhosis, pancreatitis, several cancers, diabetes complications, and mental health disorders, among others. 200 NCDs or so. Alcohol also worsens existing NCDs by interfering with medication adherence, metabolic control, and healthy lifestyle behavior. So this is a significant problem. So addressing alcohol-related NCDs, therefore, requires not only clinical intervention, but also strong prevention strategies, public education, widespread public education, and supportive alcohol policies from our governments. I want to thank you all very much. Ashley, go ahead, please. Formally
Yes.
close.
So again, thank you, Shalima, for always being a great moderator. And thank you to all our speakers again for your very informative presentations. Thank you all for taking the time to attend and participate. As was said earlier, the public meeting is being hosted by the Indo-Caribbean Cultural Center. Feel free to contact the ICC to publish your books. Remember that we are asking you to kindly give us your suggestions. If you give a donation, your name will be placed on our poster and all promotional materials. Please contact Dr. Mahabir for details. Our next topic next Sunday will be laughter and yoga for health and wellness. With that being said, thanks to our planning team led by Dr. Kumar Mahabir and Shalima Mohammed. Thanks to our IT consultants, Daryl Gransam and Navin Mangal. And thanks to Daryl again for designing the poster. Please visit, like, and subscribe to our YouTube channel and see all our past recordings. I am Ashley Sananan from Trinidad and Tobago in the Caribbean saying goodbye. May God bless you all. Dhanyavad.
Thank you all. for joining and staying this long. So I'm going to step